Welcome to the learning video presentation of the Swan-neck curled catheter. Swan-neck curled catheter is a peritoneal catheter that has a preformed 150 to 180 degrees bend and has two downward pointing segments with a double cuff. It was a catheter chosen because it is widely used and its structure prevents migration of the catheter, thereby helping outflow. Let's learn more of the material, use, advantages, and disadvantages of this type of PD catheter. The downward insertion is thought to prevent migration of the catheter and prevent infections at the exit site, while the coiled intraperitoneal segment are believed to cause less pain during the drain cycle. There is no known disadvantage for this type or any other types of catheters. There are no studies that provide evidence that one element of catheter design provides better outcomes in terms of mechanical complications. Mechanical problems associated with the PD catheter have more to do with the proper insertion technique than by catheter design. A full preoperative assessment of the patient is essential to identify existing or potential hernias. If present, these can be repaired during the catheter insertion. The catheter exit site should be determined before the catheter is inserted. The preferred site should be first discussed with the patient. These are the points to be followed when determining the exit site. The site should be determined while the patient is in a relaxed sitting or standing position. It should be either above or below the belt line, whichever the patient prefers. Skin folds and abdominal scars should be avoided. The catheter exit site should be located where the patient can effectively carry out exit site care. Once the exit site has been determined, it should be marked clearly with a permanent skin marker. The patient's lifestyle, work, and hobbies should be taken into consideration when placing the catheter. On the morning of the operation, the patient should be bathed or given a shower. If necessary, Abdominal hair should be clipped. Constipation is a major cause of catheter failure, particularly at the start of PD, and it is therefore recommended that a strong laxative is given the day before the catheter insertion. It is also important that the patient has an empty bladder before the insertion procedure takes place. It is advisable to screen all patients for Staphylococcus aureus prior to catheter insertion. There is evidence that patients who have nasal carriage of this bacteria have an increased risk of exit site infection and peritonitis. The use of mupirocin cream or ointment at the exit site is recommended to reduce the incidence of infection. Prophylactic antibiotics are used to prevent catheter infections and peritonitis and are recommended to be administered at the time of catheter insertion. It is important to discuss client about sexuality and body image. Having a PD catheter present in the abdomen may inhibit the patient or the partner, so it is essential that anxieties and sexual challenges are considered. Directly following the insertion of the catheter, it may be flushed with 500 to 1500 ml of PD fluid to check patency. It may then be capped off using a small locking cap on the catheter adapter and left covered until PD commences. Before discharge from the hospital, during the resting of the patient's catheter, clear instructions must be given as to the correct procedures for caring for the catheter at home. Ideally, the exit site should be undisturbed for 7 to 10 days following the insertion of the catheter. The patient may be discharged home during this period. If during the first 10 days the dressing becomes soiled, it should be redressed by a nurse. If it merely becomes dislodged, it should simply be replaced with a fresh sterile dressing. During this period, the catheter tubing must be immobilized by securely taping it to the patient's abdomen. Local unit policies will be in place and should be followed. The goal of wound care is to keep the site clear of exudate or debris that could encourage bacterial growth. A method of exit site care that best fits with the patient lifestyle is most likely to encourage full participation in the treatment and therefore reduce the risk of complications. Discuss your preference with your home care nurse. Harsh solutions should be avoided as they have the potential to cause skin damage, which may predispose to bacterial colonization. Whichever wound care is used, it is important to ensure that the exit site is carefully dried to avoid skin maceration, which could also predispose the site to bacterial colonization. The use of no dressing and a simple exit site care routine for a well-healed exit site will appeal to many. However, most centers do use some kind of cover. From the moment the catheter is inserted, it should always be securely anchored to the patient's skin to avoid torque movements at the exit site and potentially reducing the exit site infection. This can be achieved by using a tape or a commercially available immobilization device or tube holder. Swimming and bathing can be discussed with patients once the exit site is fully healed and ideally free from infection. A waterproof or occlusive dressing should be placed, the exit site should be cleaned, and a new dressing is placed immediately after immersion in water. It is not recommended to immerse the exit site in water without waterproof dressing, particularly hot tubs, jacuzzis, and so forth. Diving should be avoided as this may put tension on the catheter at the exit site.